Welcome to Navicent Knows Health. I'm Cindy Busby and I'm here today with Dr. Eli Penn. He's a board-certified gastroenterologist, and today we're going to talk about his practice here in Central Georgia. Dr. Penn, thanks so much for being with us again.
Thanks for having me.
When it comes to treating gastroenterology conditions or GI conditions or stomach or heartburn, what are some of the symptoms that patients are experiencing that they might not even know are related to their GI tract?
Well, commonly patients with reflux disease will present with atypical symptoms such as chronic cough, hoarseness of voice in the mornings, or even adult onset asthma. And many of these patients will not have heartburn, so they don't recognize that they have acid reflux.
Mm-hmm. When do those hoarseness and chest pain or those kinds of things, when are they likely to present? Are they certain times during the day that these patients should be not ignoring these symptoms?
Usually the mornings are the worst time because the reflux has been occurring all night, and a small percentage of the reflux has gotten onto the vocal cords or into the airways and has to be cleared.
Mm-hmm. When we talk about reflux, what is the substance that is coming from the stomach up through the esophagus to the vocal cords or the airways?
So probably most importantly, hydrochloric acid, which the stomach makes to sterilize the things we eat, but also bile from the bowel and other digestive enzymes in small quantities. So a lot of toxic substances that the stomach is designed to contain without injury, but in the esophagus and airway they do significant damage.
Is it part of the myth around GERD or heartburn that eating spicy foods or eating too much, are they really things that cause it, or do they just exacerbate it?
The latter. So they do exacerbate symptoms, particularly pain. Mm-hmm. But pain is only one of the symptoms and problems associated with reflux. So even when patients have no heartburn at all, the problem is still ongoing, and that's part of the reason that there's growing dissatisfaction with our treatment, which for the past 20 years has been to suppress acid to avoid pain. More and more we're realizing that just stopping the pain does not stop the problem or the consequences. Is
heartburn ever linked to things that are physiologic, like obesity, or maybe some of the way the esophagus works? It's like it allows it to happen more easily?
It is. So obesity raises your risk of having GERD, but I have many patients who are perfectly thin and experience bad reflux. As far as reflux being physiologic, we don't think there's any physiologic function, no normal reflux. Certainly there is some acid exposure in the esophagus, but it should be very minimal.
What are some of the things patients do, or you find they do, prior to getting referred to you?
So most patients have learned to avoid triggers such as spicy food or excessive alcohol consumption. Some have gone so far as to avoid eating before bed or elevating the head of their bed. And almost every patient has tried over-the-counter remedies like Tums and now Prilosec.
Does heartburn or GERD, is that something that is on a continuum, or is it something that sort of happens and then people begin experiencing it, or maybe it's happening but they didn't know? Mm-hmm.
I think structurally normal patients will have occasional heartburn, maybe once every 5 years, but people who have regular heartburn are structurally abnormal, and it's a chronic condition. It doesn't go away. Often the highest risk patient I see is a middle-aged male who used to have terrible heartburn and it stopped because they have lost sensation and do no longer feel pain, but their heartburn or their reflux is completely uncontrolled and doing damage.
Once they really get to your office, what are some of the ways that you're treating it procedurally?
Mm-hmm. So things have changed a whole lot in the last 5 to 10 years. A little background of treatment of GERD, because it's been around a while, is that in the 1950s, 60s, and 70s, the Navicent fundoplication was the sort of Cadillac treatment for GERD, and we would repair hiatal hernias, which are at the basis of a lot of GERD in patients. And then in 1989, when Prilosec was introduced, gastroenterologists embraced it wholeheartedly. And in the time since 1989, we now have 40 million Americans on a daily PPI like Prilosec. We did not foresee some of the consequences of that. It was only studied to be given for 8 weeks at a time. And the chronic use leads to some serious physiologic consequences and doesn't really address the mechanical problem with the disease, where bile and enzymes are refluxed. It just takes some of the hydrochloric acid away. In the meantime, in the last 10 years, newer ways to repair a defective lower esophageal sphincter, which joins the stomach and esophagus, have surfaced, which are safer, more effective, less likely to come undone, and more easily repaired if they do come undone. And so the balance has shifted, or is shifting, in favor of the true repair of reflux, which is to fix the lower esophageal sphincter in many patients.
So when we think about the esophagus as it goes to the stomach, it actually closes itself. I mean, it's supposed to be closed off. What are the procedures that you're doing where they're conjoined there? What is it, the mechanism that can keep it closed?
Well, so first I'll tell you what the way that the sphincter fails. It actually has to do with multiple muscle groups. It's not a simple sphincter. The hiatus, when we say hiatal hernia, the hiatus is the normal hole in the diaphragm that allows the stomach in the abdomen to join the esophagus in the chest. When that hiatus widens via stress or degeneration, the stomach can get pulled up into the chest, even a few centimeters, and that's all it takes to completely negate the function of the sphincter, so you cannot stop acid. If we look closely enough, anybody with reflux can be seen to have maybe even a minor structural abnormality, and that's all it takes to lose the sphincter function. So we've designed endoscopic procedures for small defects where we can restore the 1 to 2 centimeters of stomach to the abdomen, and then affix the stomach to the esophagus below the diaphragm so that it will hold. And that's called the TIF procedure. Those patients do extremely well. It's well studied. And larger defects, I routinely send my patients to one of our GI surgeons to be considered for a variety of types of hernia repair that have surpassed the Navicent fundoplication and have far fewer complications. So it's an exciting time as we all start to realize, both gastroenterologists and surgeons, that we're really on the same team and we've taken different angles, and the truth is somewhere in the middle. And so we're working together like we haven't in decades to get the best outcomes for our patients.
When it comes to things like Barrett's, or when you're looking at potential cancer in the esophagus, can you talk a little bit about some of the treatments that you do for Barrett's?
Absolutely. So Barrett's is a precancerous change in the lower esophagus, usually due to chronic acid exposure. And Barrett's is the precursor for esophageal adenocarcinoma, the most common type of esophageal cancer now. Unlike all other cancers, which are relatively stable in their incidence, esophageal adenocarcinoma has risen 9-fold since the 1970s. It's very, very important that GERD patients get examined for Barrett's, as important as the pap smears are for females, because when we find Barrett's, we know that the patient is at high risk for cancer. We either monitor them or we get rid of the Barrett's altogether with various ablation techniques. And it's extremely important, if you get nothing else from our time today, that if you know a loved one or you yourself has reflux, to get checked for Barrett's.
Today there's no annual screening for GERD, or other than a checklist you might get with your primary care physician?
That's right. And there's the only guideline we have so far is a one-time screening for men over 50 with a history of GERD. And men are twice as likely to get esophageal cancer, but that really sells women short who, despite the lower incidence, it's still very high. What I tell patients is that we do a lot of very exciting, technologically advanced procedures, but hands down, the biggest impact we have on our fellow men and women are screening colonoscopy. And it's a little bit of a paradox because the people who need colonoscopy the most never feel like they need one. And the people who want one, it's always too late. So it can be a hard sell, but it is extremely important. Colon cancer is the second most common cause of cancer death. And 1 in 18 Americans will get it in their lifetime. I'll mention that African Americans we know develop colon cancer at an earlier age. I was part of the research that showed that about 10 years ago, and we shifted the guidelines to start them at 45. That has not really taken off like we had hoped, partly due to insurance resistance in the beginning, but I think now every major insurance carrier covers screening colonoscopy for African Americans at 45, and that is when they should start because there's not any more cancer in that ethnicity, but it certainly starts earlier.
What are some of the things that GIs do when it comes to swallowing?
Well, the first thing we think about is a critical finding like a growth or a tumor. But once we've ruled out a structural problem with the esophagus, it's very, very important to follow up with a motility evaluation. Most people don't realize that the esophagus has a very complex motor that's unfortunately easily deranged, and even a drop of water will stick to the wall of the esophagus and not go anywhere without a systematic wave of contraction. Now, patients will often give a history of GERD because they think that what's coming back up must be the reflux that others feel, but in fact it's not from the stomach. It never left the esophagus, and when they eat they get full quickly because their esophagus fills up all the way to their mouth. They choke frequently, but an endoscopy can look normal, particularly if it's done rapidly. We do a test called manometry where we actually measure the pressures and the peristalsis in the esophagus, and we can find one of many disorders, including achalasia, which used to have very few treatments. The more modern treatment, but still 40 years old, is the Heller myotomy, a surgical cut in that muscle to relieve the contraction and let people swallow. The most modern, it's about 9 years old now, is called POEM, kind of like a poem you would read in a book. It stands for per-oral endoscopic myotomy. So with an endoscope, we are able now to tunnel through the layers of the esophageal wall until we get to the dysfunctional sphincter and incise it, actually cut it through and through so that it separates and opens permanently. And this is a great relief to people with achalasia. It reduces the risk for aspiration pneumonia, squamous cell esophageal cancer, and not to mention allows them to eat fairly normally. So,
well, thank you so much for telling us so much about your practice.
My pleasure.
And thank you for joining us at Navicent Knows Health. If you'd like to know more about Dr. Penn and his practice, please visit us at navicenthealth.org.